Hello, everybody from Northern California. I'm Will Hall, and welcome to Winds of Change, New Trends in Mental Health. I think I got the name of the conference right. Thank you so much to Milam, Jerusalem, and to Esther, and everybody who's been organizing this conference. I'm excited to be here because we have work to do. There's a lot of change that needs to happen, and there's a lot of change that is happening. I want to really thank all of you for being here, the professionals who are here, the people who are doing the work. Especially I want to thank the family members, because we know that family members are suffering too. An individual is in a web of relationships. The family is often the closest, and the family suffers too. And the family suffers twice, because they suffer because the person that they love is struggling. Also, they suffer because they have to kind of pick up the pieces from where the mental health system is falling apart. The mental health system isn't doing its job for many reasons, and so the family has to step in. You see, I see so many times when family members have that burden of being the case manager, coordinating the care, finding new doctors, finding better situations with medications, dealing with housing, that families have to step in because the system has so many problems. So I want to really welcome the family members. And especially, I want to welcome those of us who have been diagnosed. Those of us who have been in the system, who've been in hospitals, who've been in residences. I've been in homeless shelters, people who, like me, have taken medications. I want to welcome all of you. You have the experience. You have the first-hand experience. You are like first-person participatory researchers on the most important reality that we need to face here. What is it like to go through a mental health crisis? What is it like to experience emotional distress? What is it like inside of depression, psychosis, what gets called obsessive compulsive or attention issues, or what gets called bipolar? Because from that first-hand knowledge, that's how we build good care, and that's how we build science, and that's how we build understanding, and that's how we find what people really need. So I especially want to thank all of you clients, patients, survivors, people in the system. One of the first things that I'm very interested in reminding everyone of, because I think it's a very common sense thing, is that when someone has a diagnosis, let's talk about a diagnosis like schizophrenia. I was diagnosed with schizophrenia, a kind of schizophrenia called schizoaffective disorder, and I've had a number of different diagnoses before that. But let's talk about something very important, because typically when you hear someone has schizophrenia or someone has bipolar, the tendency is to think that that's a trait of that person. They have blonde hair. They have 6 feet of height. They have schizophrenia. And I want to really challenge that. I want to really say, instead of seeing schizophrenia, psychosis, bipolar depression, any of these mental health disorders, instead of seeing them as a trait of the person, I want you to see them as a moment in time. I want you to see them as a chapter of that person's story. So there is a stereotype around homeless people, that homeless people are those people over there, and they're homeless, and they're kind of always homeless, they've always been homeless, and they're just sort of but wait a second, you think, wait a second, no, it doesn't make sense. Every person who lives on the streets, and we have a real serious problem with this in the United States and many, many places, everybody who lives on the streets has a story. So living on the streets is really one chapter in their story. They weren't always living on the streets. You know, there's a whole story, there's a whole process. You're seeing them a moment in time. And crucially, we don't know what the next moment is going to bring. This is one of the most important shifts I think we can make in understanding what gets called mental illness. That these are not traits of an individual, these are moments in time in an individual story. They could be very brief, moments of time. If you look at the history of the schizophrenia diagnosis, there used to be something called schizophrenic reaction. So schizophrenia meant your mind sort of falls apart, but it's a reaction to a certain situation. The person might go into a schizophrenic, say, episode or time period or chapter, and then they come out of it. And that has been the understanding of mental health diagnoses historically from the beginning of psychiatry. And then something happens where in the 80s and the 90s, this biological perspective comes in, where it starts to say, well, schizophrenic brains are different. ADHD brains are different. The genes of people with bipolar are different. And then instead of seeing someone going through a mental health distress like a moment in time, like someone going through homelessness, we start to think, wow, that person is this way. They are a schizophrenic. Now, think about that. If we were to go around and see people who were homeless and say, oh, this is a homeless person. They have they have domicile deficiency disorder. They have an innate trait, a genetic or a biological trait that just makes them not have the nesting instinct. And so they just can't stay in a home, and so they end up just being on the streets. Now, that would be a terrible disservice to that person, because we've created the expectation of permanency. We've created the expectation that their chapter is actually the entire story, that the story ends with this chapter. We've created the expectation that a circumstance is instead a trait of that person. So let's step away from seeing mental health diagnosis and disorders and mental distress as traits and start to see them as a human being, a whole human being, a fully human person is going through this moment. It may be a brief moment, and some of you may have even had a psychosis that was brief. I mean, you can have a psychosis from sleep deprivation. You can have a psychosis from a medication side effect. And sometimes people have a very high fever and wow, they're in another world. That maybe that's brief. Maybe it's longer. Maybe it's pretty long. I mean, I was struggling. I was on disability for 15 years. I wouldn't say that I was psychotic for 15 years, but doctors would say, yeah, this is a trait, that you're a schizophrenic, you can't work, you're on disability. And so whether it's a brief moment in time or an extended period of time, if we have that attitude that this is a moment, then we have a very different set of questions and set of approaches. The first question is, well, what was going on before this happened? What is it that led you into this? When I went into the psychiatric hospital, they didn't ask me any of that. They interviewed me, they observed me, and they decided that I had the trait of schizophrenia. They assumed that because there were other people in my family who had also suffered, that it was genetic, and that I was somehow just had a broken brain, and I really should just take my medications, and I should really lower, they literally said, you should really lower your expectations for your life. You should not have a stressful career. I had been involved in the environmental movement. I'm very proud of the work that I did in the environmental movement. Don't go back to that. Just take medications, manage your symptoms. This is a lifelong. They were into thinking of things in terms of traits. And this was a disaster for me. This was a disaster for me, because I was actively discouraged by the system from asking the questions that might go along with seeing it as a point in time. I was just like, oh, they finally figured out what's wrong with me. Now if I just do what they say, I didn't even know what was going to happen next. I guess I'm just going to always be like this. Then, years later, I started to ask some questions about my own family experiences. I started to connect some dots. I started to read and learn about trauma. I started to read and learn about childhood neglect. I started to read and learn about family systems. And what I learned was that, the fact that both of my parents are very severe trauma survivors is absolutely part of what I went through. And I don't blame my parents, I don't blame my family, but like I said before, they were in trouble too. They were in crisis too. They needed help too. My parents didn't get the help that they needed to deal with their trauma. And so they weren't as equipped to really support me in the way that I needed to be supported. I also had trauma bullying in school. I experienced very bad bullying, and I have some other experiences of violence. So now I start to think, well, actually, I'm not as schizophrenic. I'm someone who has this period of their life when I'm going through something because of some kind of buildup, because of some kind of context, because of some kind of previous chapters. And then I think, okay, maybe there's future chapters that might be different. Now, when someone has been stuck for a long time and they don't seem like they're moving or changing, it's hard to think of it as a moment in time. But that's what we need to think about, because if you're stuck and you think it's just because of who you are, then you're not going to think about trying different things in the future. If you're stuck and you're thinking, well, maybe this is a moment in time, then you think, what have I tried in the past? Maybe I can try something different. Maybe I can try something different. So I was hearing very aggressive voices telling me to kill myself. I was so frightened of my roommates that I wouldn't leave my room in the apartment, and when I did leave, I would climb out the window. I would walk the streets of San Francisco. I would see people. I would believe that they were watching me, they were trying to hurt me, that their thoughts were coming into me, and I would have to run away. I believed that the devil had sent me a postcard and was coming after me. I was very, very psychotic, you could say. And I want to take a step back from that word, because again, it comes into trait language. It starts to say, oh, there's something wrong and broken with me. Was there something wrong? Yes, but it may have been going on in my life. There may have been something very stressful and difficult and wrong in my life going on. And when I was in the hospital, I was put in restraints. I was given all kinds of different drugs. I was put in isolation cells. No one was ever really listening to me or giving me a space to try and understand myself and try and understand what I went through. And no one was really encouraging me to think about making changes other than which medication are you going to take. And I'm not anti-medication. I see people are helped by medication, but a lot of people, they're not getting better on their medication. And they need to start trying something different, either a reduction of the medication or trying something different in their lives, because feeling miserable on medication is no way to live, and then you're just telling yourself, well, it could be worse. That's not much of a life to think, oh, things are terrible now, but it could be worse. At least I'm not psychotic. At least I'm not in the hospital. Yes, this is important. This is an important way of understanding it, but there's a lot more to look at. So when I was in the hospital, I wasn't being listened to. I wasn't encouraged to make those connections. I wasn't really given any opportunity to try new things. And this, I think, would be the second important message that I want to get across, is that people who are in emotional distress states need to be able to be given some time to kind of experiment with different possibilities. You need to be given an opportunity to learn. Because I was learning, even though I was stuck, even though I was hearing voices, even though I was suicidal, even though I was extremely paranoid, I couldn't look people in the eye. I went through many, many weeks of not being able to speak. I was learning. I was trying things. I was listening. I was paying attention. No matter how far away somebody is, no matter how lost in an altered state they seem to be, there's somebody home, somewhere. On some level, they can feel you. People, I would be interviewed, I would be sitting in the chair in the clinic room, I would be interviewed, and they would talk about me like I wasn't there, because I was so quiet and frozen, and my head was down, I wasn't making eye contact, and I didn't speak at all. So eventually I just became invisible. But it wasn't that I was gone, I was actually very alert, because I was in these protective states. I learned that when a child grows up in a chaotic, traumatized context, that it has effects. And so I was experiencing a lot of protection and a lot of trauma effects. And I was experiencing a lot of coping mechanisms. I learned how to deal with my childhood stress by learning certain kinds of protective mechanisms. So I think it's super, super important for us to understand that people can experiment with change, they can experiment with learning, and they can discover that some of their protective mechanisms from the past maybe are not working for them in the present. Now, you may notice that I'm talking a lot of common sense kinds of things that everyone has to face and everyone can benefit from, because I think that's the message here. It's our common humanity, that all of us have a similar kind of struggle before us to come to terms with who we are and to learn better ways of moving forward. And that's no different for someone who's bipolar or diagnosed bipolar or diagnosed schizophrenic. So I started to make explorations, and a lot of those explorations didn't work for me. Staying in my apartment, getting a disability check, I had a small studio apartment, but it was safe, and I would play video games or watch videos. And I did this for like a long time, like months and months and months into the years. And I was experimenting. What's this like? What is this going to? Didn't work for me. Eventually, I had to try something else. So I go for a long period of time where I'm not working, where I don't leave the house. And I thought maybe that was because hiding as a child, as a young man, had been such a successful protective mechanism. I think I'm just going to keep trying hiding. And eventually I realized that didn't work for me either. But it took time. And then I said, okay, well, maybe I'll try getting involved in the community. Maybe I'll try volunteering. Maybe I'll try working a part-time job. The reason I'm emphasizing this idea that people are learning and experimenting is that typically the system says, you have this trait of schizophrenia. There's nothing you can do about it. And just take your medications and let's see if we can, optimize your life as much as possible. Actually, the truth is that the research shows that I'm not the only one. I wasn't misdiagnosed. I was at University of California, San Francisco Medical Center, one of the best teaching hospitals in the world. They didn't misdiagnose me. I had all the criteria of schizoaffective disorder, schizophrenia. And if you look in the research says, yes, people do recover. People get out of it. People move on, even without medications. Some people find that medications are actually what held them back. Medications were holding me back. They weren't working for me. So throughout the research literature, there's always been known that, yeah, there are some people that can make it. Some people can make it and move on with their lives. Some people maybe have a harder time or they remain stuck. Other people are in this more in-between place. We've lost that. Now it's just everybody's chronically disabled. The best that you can do is just take medications and lower the expectations from your life. And that's it. We've lost this experimental learning attitude that treats the person like a person trying to figure out how to move from that chapter of homelessness or whatever it is, schizophrenia, bipolar diagnosis, whatever it is, to move to the next chapter. And we really, really desperately need the mental health system to take an attitude of the possibility of recovery. I was given like a self-fulfilling prophecy. No, this is who you are. No, it's not going to change. Just take medications. That's the best we can do. Here's a disability check. That's it. Rather than, well, we're going to be honest with you, Mr. Hall. You have an experience that gets called schizophrenia, but it's mysterious. We wish we knew more about it, but we don't. To be honest with you, medications is what we offer a lot of people, but some people, in fact, a lot of people don't like their medications, and for some people even seems to make them worse. For a lot of people, it doesn't even make them better. It might help you, it might not, but we're going to be honest, we don't know. And the reality is, Mr. Hall, that some people stay stuck. Some people seem to get worse. Some people get a little bit better. Some people actually are able to find a way to walk away from the mental health system. Now, to be honest, we don't know which one of those categories you fit into, because that's also what the research says. There's been no way to predict the outcome of a bipolar or schizophrenia diagnosis by any kind of assessment of the person. You can talk about, well, there's premorbid functioning, there's early onset versus late onset, there's the comorbidity of alcohol and drug abuse, and these kinds of things, the history of other people in the family. You can talk about that, but that's statistics. When someone is right in front of you, you don't know. You might as well just flip a coin. You don't know which person which group that they're gonna fit into. So that makes it especially important to treat it like a chapter in the person's life. You don't know what the next chapter is going to be like, because you honestly don't know. As a scientist, as a doctor, as a professional, as a family member, you really don't know. If the possibility is 1 in 1,000 that the person is going to get better, that is not 0 in 1,000. 1 in 1,000 comes up every 1,000th time. 1 in 1,000 means that 1 out of 1,000 people is, you see what I'm getting at. So even if there's not a likelihood, even if there's not some sort of like, being romantic or being like, oh, we're just going to be, incautiously optimistic or something, even if we don't have to exaggerate the possibility, we have to hold the possibility open, because people surprise you. They do. And if you hold the possibility open that today's a new day, let's see what happened. Let's see if that learning has taken place. Let's see if a new possibility emerges. If you take that attitude, the person can feel it. They can feel it. If you've given up on them and say, oh, well, nothing's ever going to change, they can feel that. If you say, well, this person hasn't made a change, they're probably not going to make a change, and so I'm not going to count on a change, but they could surprise me. It could happen. So I'm going to give them a chance to learn. I'm going to give them a chance to explore. Wow, he tried to have a job 4 times. He wants to try again. Every single time, he's so disorganized. He doesn't do it. He gets fired every single time. He wants to do it again. Okay, we're going to try. Let's talk. Let's see, what do you need this time? How can you maybe do it this time differently? So, of course, there have to be balances. There has to be some kind of limits and sort of considerations on the learning process, that you can't just keep, being given an apartment and $1,000, and then you destroy the apartment and you lose all the money, and then your parents are just going to give you another $1,000 in another apartment. Of course, there are limits, but we can put the limits in. We can be thoughtful and rational and caring about the limits to ourselves and our own boundaries without giving up that attitude of, well, it's not impossible. We're not sure. This is a moment in time. So that's one of the key things that really helped me, was to start to see myself as a moment in time. And I'm going to talk a little bit more about that and what I think the role of families and professionals should be after the break. So thank you very much. Hey everybody, welcome back from the break. We were talking about this shift of thinking from seeing the trait in the person, that something is wrong with the person, to thinking about a whole life story. And there is a chapter in the story. You don't know what the chapter that comes next is actually going to be revealing about that person. And I told you that I had made a shift in seeing myself as broken and seeing myself as just having a trait, and starting to see myself as a learner who's moving through a chapter in my life and I don't know what's next. And one of the most crucial things to get me to make that shift was the patient survivor movement. And I had therapists to talk to. I had talked to my family a little bit. It was very hard to talk with them, but they didn't give up on me. They never abandoned me. I had talked with doctors. I had talked with social workers. I had talked with vocational rehab counselors. I had talked to friends. I had talked to all kinds of people. But it wasn't until I talked to people who had been through what I had been through that things really started to change. So if there is one thing that you can do in Israel to change the mental health system, I would say to get more resources and support into the patient survivor movement. And you may say, well, what are the patients and survivors doing? What is the innovative treatment? What is the incredible magic secret recipe that they... It's very simple. Friendship. Friendship. Because trauma and neglect and isolation and the kinds of things that I went through, the bullying, all of that makes you lose connection. And we can talk about all the different characteristics and diagnostic criteria of mental health, but it really comes down to isolation. The person has lost their connection. They may be surrounded by a lot of people trying to help them, but they don't really have that connection. And I didn't have that connection. I didn't trust people. I would talk to people. I eventually started to be more social, but in a very, very guarded way. I was even guarded from myself. There were things inside of myself I didn't even know I was hiding from myself. And then I found my way into the patient survivor movement and into support groups. And I started listening to people, and they started listening to me. And there's a lot of things that we can talk about that other people can't talk about. When you've been put in restraints and you've been put in an isolation cell, you have a certain kind of rage and resentment that other people just aren't going to understand. There are things that happened to me with doctors or with nurses that were very violating, very humiliating. And it takes another patient who's been through that to understand that. And also, I was hesitant to say, well, I had some positive experiences with nurses or with doctors. And there was this guy, and he treated me badly, but he also treated me well. I would be hesitant to explain that and discuss that in that depth of the complexity of my feelings, unless it was with a friend who was from the patient survivor movement, who could really relate to what I was trying to say. And so slowly, I started to rebuild this muscle of relatedness and connection. I was out of the habit of being a human being, in a sense, not out of the habit of being a human being in the sense of being a physical human being, but out of the habit of being a human being in the sense of being treated by others as a human being and being part of society. I had lost my familiarity with that. And I also was, it took me a long time to realize that I had lost touch with my own sensitivities and my own needs and my own vulnerabilities. That, some people, they get along fine, they have friends, they go hang out, they play some sports, they have their job, and okay, they're doing fine. Others of us, we're really sensitive, and we need deep friendship. We need alone time. We need spaces for our emotions. And we have just as much a right to be here as everybody else. And it's harder for us to find a place to fit in. The patient survivor movement gave me a place where I felt like I belonged. And that may sound like a simple word, belonging. But if you don't have that, it can be devastating. If you don't have a sense of contribution, acceptance, appreciation, being valued, being seen, being understood, it can devastate you. I know a lot of people in society live without that sense of belonging. It's become kind of normal in the United States. We're a very isolated society, but people suffer and they get along and they kind of like numb it out and binge on Netflix and drink your alcohol or smoke your cannabis or just kind of go on, shuffle through life. And a lot of people live like that. A lot of people can't. We just break down. We just fall apart. Our whole system, our whole body, our whole psyche rebels against that. So slowly, I started to realize I have sensitivities inside of myself, and I got to talk about some stuff. I got to connect with people. This was many years. I went back to therapists. I got fired by therapists. I wasted lots of money with therapists. I tried to go back to school. I went back into the mental health system, 6 years after I had been in the first time. I was kicked out of houses. I was homeless again. All these different things happened. This was a process that was like 15 years that this process took me. And, or even longer, because I had started before, things started to unravel even before I got on disability. So, but it was a process. It was a learning process. It was a trial and error process. So now I've become fascinated with the question, how do we speed up that process for people? How do we give people some of the ingredients that I had, but sooner and stronger and more in a more profound way to kind of get the process going faster? And I have some, I think have some preliminary answers to that question, how can we speed it up? One of them, I've been saying it quite strongly and repeating because I think it's so important. Stop treating people like they have a trait, their beingness, there's something wrong with them, and see them as just like you, just different circumstances. They've got a different situation that they've been dealing with, and for whatever reason, they broke down, and now they're in this chapter of life. So treat people like they are a moment in time rather than there's something wrong with them. Always see people with an optimistic possibility and expectation. And the reason I say that is not because I expect that everyone I meet and work with as a therapist will recover and will make it through like I did, or will make big changes in their life, but because I know that if I treat them like they can, and I do have some optimistic expectation, they can feel it. They can feel it. If you're a boss at a job and you have a new employee and they make one mistake and you focus on their mistake and you say, look at that mistake you did, that was a terrible mistake, it cost me money, guess what? That employee is more likely to repeat the mistake than if you say, okay, you made this mistake, but that's okay, it's part of the learning process. Everybody who starts here, they make a mistake. Don't worry about it. I know you're going to do better next time. How many management books about managing employees have been written about how that's a fundamental truth? The expectation that you convey to the employee actually influences their behavior. A positive expectation increases the likelihood of a positive behavioral outcome. So treat people with a certain expectation that yes, they can potentially get better. Stop with the self-fulfilling prophecy of no, they're probably, it's not going to happen. Let's create people can feel that. They can create that. They can feel that kind of social death sentence. We've given up on you. Another thing I would say is we really need to start to get smarter about medications. I'm sorry, 100% of the people taking medications don't get better. I'm sure there are people watching this video right now who are on your antidepressants or on your benzodiazepines, and you've been on them for a while, and you're like, well, I don't really think this is helping me. Maybe this is actually making me worse. This is also true of the antipsychotics. It's true of the so-called mood stabilizers, and lithium sometimes can be helpful, especially for sleep, especially for short-term crisis, especially for the person who's just completely out there. We need to get them back on their feet. But this idea that long term the person is going to stay on medications and they have to stay on medications, this unfortunately creates problems for some people. It can actually even change the brain chemistry so that it makes it hard to come off the medications, and it makes it so the person is actually more likely to go into a psychosis or into a crisis because you've been giving these medications that increase the sensitivity of the brain. And it's also especially true of lithium. So let's be more careful with medications, and let's start to, I know Shimon Katz and some other people have been doing some work trying to create some alternatives, some openings for seeing, well, let's give this person an opportunity to see what it might be like to reduce medications or come off their medications. I've done a lot of educational work around what we know and don't know about doing that more safely. So let's be cautious and careful about medications. With families, this is what I said in the early part, I really want us to understand that the whole family is in crisis. Not just the person who's staying in their room and won't come out and is hearing voices and has a diagnosis and is struggling with their medications. This affects the whole family. It affects the whole family. The suffering may not be on the surface. Some family members may be suffering more than others, but the whole family is affected. The whole family, therefore, needs to go into recovery. The whole family, it's a mutual process. The family also needs to say, I want my son or daughter to change, and I'm going to do the hard work of making change in my own life. Sometimes worrying about your son and daughter might not be what they need. They might need to see mom and dad being happy or reunited in their love and their relationship, or mom and dad not focusing and worrying so much on them. So, like I said before, learning and experimenting and trying things. If things in a family are stuck, try something new. If kind of providing safety has been going on for a long time, maybe allow a little bit of risk taking, just a little bit of experimenting, a little bit of trying things. It's okay if there are failures. The failure is not the end of the road, because failure is how you learn things. You try and you fail, you try and you fail, and then eventually you learn how to succeed. That is the process for many people. I work a lot with families. What I see is that often the young person is going from adolescence to adulthood, and the parents are having struggles with that, just like parents throughout history have always had struggles with helping adolescence through adulthood. Sometimes people are struggling with adolescence through adulthood into their 30s and 40s and 50s. I was struggling to be an adult into my late 30s and my early 40s. The capacity to try things, to learn, to make mistakes, to maybe fail, to maybe learn the hard way, this is very, very important. I would really recommend that everyone get familiar with the experiment that's happening around the world with open dialogue. Open dialogue is a mainstream treatment approach in a part of Finland, Western Finland, where basically they say, hey, we're not going to be we're not going to be in such a rush to use medications. We're going to allow this process to be explored and be discussed and be talked about. We're going to involve everyone. The professionals aren't going to go behind closed doors and come up with a scary diagnosis. We're going to talk with you as human beings. We're going to entertain different points of view. We're going to listen to everybody. We're going to invite the person who's experiencing psychosis to be part of the conversation. And we're not even going to see it as psychosis. We're going to consider it as their best effort to kind of cope with something that we don't understand. So I encourage people to check out what's been going on with open dialogue, and that as a possibility. I know that there are people in Israel that are pushing for some open dialogue pilots, and that are maybe even undertaking this. I think I've heard some reports that there's some progress being made in some open dialogue work in Israel. All over the world, people are trying to follow this very inspiring example of open dialogue that has helped so many people, has so much better satisfaction from people who are participants. So I would also hope that in terms of thinking about what helped me, that we can really strengthen the peer movement, the survivor movement, just spaces for people to go and meet people and talk about their problems and form community. It was so important to me. And I think we need to take a few steps back from this idea of psychosis. I think that it's a word that really feels like an insult for a lot of people. It feels like it's a way of saying your reality isn't real. Well, yeah, okay, sometimes my reality is I just want to push it away. I just don't want to, it's a symptom. It's just part of me not sleeping. It's part of my trauma. But that's up to me to decide, because I still hear voices. I have voices that come to me, that talk to me. There are positive voices in my life. I also sometimes have very stressful and difficult voices. They come when I'm in an extreme situation, or I'm facing some kind of conflict. I don't see them as psychosis. And actually the research shows that most people who hear voices, they aren't in the mental health system. They aren't experiencing distress. They're not plagued by difficult voices. They maybe are just hearing a religious voice, a spiritual voice, the voice of God. Maybe they're hearing a voice, they're grieving, and they're hearing a voice or seeing a vision of someone who they lost. When people are in solitude, they hear a voice. People who go hiking or go off, poets and artists hear their muse, they hear their voice. So what I'm saying is that a lot of the things that we have called psychosis we throw these things into a box, and we put a label on it, and we don't actually look in the box and find out. Some people do have spiritual awakening processes and have very valid, very deep spiritual mystical experiences. It's wrapped up with trauma and dysfunction, and maybe they can't make money, or they can't figure out how to work in society, or maybe they keep getting into difficult situations. But it's for them to kind of figure out how to tease those things apart and how to manage that complicated knot, rather than someone saying, oh no, all of it is just a symptom of a disease. Because fundamentally, it's about listening. It's about the lack of connection. That's what I regained. I wouldn't say that I stopped, hearing voices, or I somehow, made it back to this reality. I'm in different realities. I have altered states. I have my visions. I see messages. I make connections. I have my withdrawn states. I have my disconnect states. I wouldn't say that what I regained was being normal. I would say what I regained is my connection. I regained connection. I regained connection with other people and the community, and I regained connection with myself. But to do that, I had to really listen to myself and really listen and be respected for who I am. Because if you have to fake who you are, or hide who you are, or you don't even know who you are, how can you make a connection with someone else? You can make a sort of a connection, but to really make a connection, you have to be more in touch with yourself. You have to express. You have to be received. That person has to be vulnerable. So finding spaces where people can make connection. Too often our therapists and our doctors are keeping us at a distance. They're treating us as a clinical object. You're a problem to be solved rather than a person to meet. And we need to have human spaces that people can go to. People need connection. And it may be that the person is, taking heavy medications, that they are stuck in their life, they are not moving forward, that they have lost a lot of different things, but they're still showing up to the group. And that's meaningful. They still have a place to go, they have a place to be, they're welcome, they're invited. And if other people can think, well, this person's been stuck for a long, because I've seen people who were stuck, they were really seriously stuck, and then something changes. They fall in love. Something changes, like, wow, they start to find a sports group that they're interested in. Something changes, like someone came along and said, we think your medication is a little bit too high. We're not going to take you off medication, but we're going to reduce it by 10%. And now the lights come back on. The person's involvement suddenly gets back online. So if someone is stuck, to not give up on them, and to recognize that maybe we need to change, we need to look at ourselves, we need to keep the door open, we need to have that expectation of the possibility of recovery, and we need to somehow allow there to be an experimental process, a learning process, a trial and error process. That if they want to try something, then we have to have our boundaries. I'm not just, like I said, just going to give you another $1,000 for another apartment that you're going to lose, but I might, give you your own room in a different house, that another family member, give you some independence, start giving you an allowance, start giving you some kind of support financially, rather than just expecting that the person can't change because they fell down 3 times. It means that they're going to fall down a 4th time. Well, they might not fall down a 4th time, especially if it's not as big of a jump. If they have a little bit of support, they can lean on your shoulder while they're trying to take that step. So this is what I do, and I do it out of my own experience of what worked for me, and I do it because the people that I work with in groups and in therapy, it seems to be helpful for them. But I just want to wrap up by saying something that's very important, very important. We need to be humbled by this experience, because when we say, why is this happening? Why is there madness? Why is there mental illness? We're asking this question that people have been asking since the beginning. Why do I suffer? Why is this happening? Why is this misfortune happening? And I'm sorry, but people have been studying that question in their world's religious traditions since the beginning. A psychiatrist comes and just says, "Oh, I know. Here's the answer. This disorder, this drug." No. We have to have some humility. We have to be humble before the fact of other people's suffering and the mystery of madness. We do the best that we can. Not me, not the open dialogue people, not the patient survivor movement. Nobody has come up with an answer that works for everybody who is diagnosed with schizophrenia, bipolar, or some kind of madness. Different people have different needs, and for whatever reason, it's a mystery. Some people continue to suffer. And my sincerest hope is that even if we are humble, that we try and we do the best that we can, and we can't seem to help this person, we don't know how, that we can be humble and say, okay, I'm doing the best I can, and I don't know what's going to happen next for this person. Maybe the next chapter is going to come. It's a possibility that some change could take place. Maybe even just a little bit of a change that could make a big difference. And to constantly hold out that attitude that what I'm seeing is a chapter in someone's life. I'm not seeing a broken person. I'm not seeing someone who's fundamentally cursed by a certain trait, and that's the end of the story. So thank you very much. It's really good to have this opportunity to talk with each other, with everyone, and I am looking forward to talking with each other and connecting. And it's been a really great honor. So thank you.